Hello, I'm Lars Wallentinv, Professor of Cardiology at Uppsala Clinical Research Center in Uppsala, Sweden. I was a principal investigator of the Plato trial, where we of course have presented many different analyses. Today I will discuss the impact of ticagrelor on mortality in the trial. Of course, we have had research support from many companies involved in research on new antithrombotic agents, among those AstraZeneca. So the Plato study was randomizing patients with acute coronary syndromes, both non-ST elevation and ST elevation acute coronary syndromes. They could be pre-treated or not with clopidogrel. They were randomized as in a real-life setting within 24 hours after start of chest pain, and there were 18,624 patients in the trial. So either they were treated with clopidogrel or ticagrelor in the conventional dose, 180 mg loading dose and 90 mg twice daily. They were exposed to the treatment 6 to up to 12 months, and the earlier cessation was depending on that we had reached enough endpoints in the trial. The primary endpoints in the trial were cardiovascular death, MI, and stroke as a composite. But of course we had many key secondary endpoints, among those cardiovascular death and also total death. And this presentation will focus on the outcome on mortality. So the primary endpoint is well known. Ticagrelor reduced the composite of cardiovascular death, MI, and stroke. And this separation of the event curves appeared early and continued during the whole trial. So you reached an absolute difference of 1.9% after 12 months. So the secondary efficacy endpoints were myocardial infarction and cardiovascular death. And there was a reduction both in cardiovascular death and myocardial infarction. And looking into the hierarchical testing of the major efficacy endpoints that we had agreed on, you can see that we could claim that there is a statistical significant reduction, not only in the primary objective, but also total death, MI, and stroke, a composite of cardiovascular death and all ischemic events, in myocardial infarction, and in cardiovascular death. Stroke did not reach significance, and total death, of course, was the strongest reduction, 22% reduction in total death. We have further looked into the mortality benefit, and if you look into this in relation to whether the patient was intended for an invasive or non-invasive strategy, and both these strategies are used in acute coronary syndromes, you can see that the mortality benefit was there, both in patients treated with early revascularization procedures and in patients without revascularization procedures. We noticed that there was a specific benefit in patients that had coronary artery bypass surgery during the trial, and we compared patients that were on study drug, that is either the randomized clopidogrel or the randomized ticagrelor treatment, within 7 days of the CABG procedure. And there was a pronounced reduction in mortality. It was halving of mortality in patients that had bypass surgery, and this has really never been seen before. It has been a concern with these intense platelet inhibitors that there might be an increase in mortality, but in contrast there was a pronounced reduction in mortality with ticagrelor versus clopidogrel. And therefore there are now specific trials starting in CABG surgery with ticagrelor to see if ticagrelor on its own can reduce mortality at coronary artery bypass surgery. We evaluated these events that occurred in association with bypass surgery. We went back and looked into the adjudication of these events, and then we found out that there were two reasons for this mortality. One was effects of bleeding, long-term effects of bleeding, which led to a reduction in mortality with ticagrelor versus clopidogrel, and somewhat astonishingly, In patients with infection, there were less infections and less fatalities because of infections in the ticagrelor in these patients with coronary artery bypass surgery. So after having seen this, we thought about what about the total trial, the total mortality difference? What's causing that? Is it the same as in the CABG surgery population, or is it something else? So we really went back and re-adjudicated all the causes of death in the total population to see what might be the causes, and we re-evaluated this in an analysis presented at this meeting, and the time to death due to infection and the time to death due to bleeding was then of course in the focus of these evaluations. And when seeing all the different reasons of death, it appears that there was a really consistent reduction in cardiovascular reasons of death, and above all there was a reduction in sudden death and arrhythmia that appeared, and that was significant on its own. There was also a reduction in other cardiovascular causes of death. There was a reduction in bleeding as a reason for death, and also infection, which did not on its own reach statistical significance. We had predefined that we should focus on the causes that we saw in the CABG population, the death because of infection, or the death caused by bleeding or related to bleeding or infection. And we could see that on its own, deaths directly caused by or related to infection were significantly reduced by around 30%. And the death related to bleeding, on the other hand, in the overall trial population was not decreased. So therefore, if we look into time to death caused of infection in the total population, then we can see that if we include the CABG-related infection-related death, of course these are higher and lower in the ticagrelor population, but also if we exclude the infections related to CABG, also if we look into other infections, there is a lower rate in the ticagrelor treated patients. So, to summarize, ticagrelor reduced total and cardiovascular mortality, and arrhythmia and sudden deaths were significantly fewer with ticagrelor compared to clopidogrel. And deaths caused by other cardiovascular events such as acute myocardial infarction and heart failure were numerically fewer among the vascular deaths. Infection, either as the direct or contributing cause of death, were significantly fewer with ticagrelor than clopidogrel. Bleeding as direct and or contributing factor was, as a matter of fact, similar in the overall population. And non-vascular deaths caused by infection were numerically fewer caused by ticagrelor. So overall, these findings, especially reductions in sudden deaths and infection, are the most likely explanations to the mortality reduction in Plato. And I think it's important to note that this mortality reduction with ticagrelor versus clopidogrel, which really has never been seen with any other P2Y12 inhibitor, either in comparison to placebo or to clopidogrel, this mortality reduction comes at a low cost. So the cost per life year gained is low. In Swedish crowns, it's 21,300, corresponding to around 24,000 euros per life year gained, or about $30,000 per life year gained. And this is as low cost as you have if you go for early invasive procedures in these patients with acute coronary syndromes. And the cost is considerably lower than with prasugrel, and even lower when we started clopidogrel treatment in comparison to placebo. So, in concluding, treatment of patients with ACS with ticagrelor as compared to clopidogrel reduces total mortality and the mortality is caused by less arrhythmia sudden deaths, less cardiovascular deaths, less deaths related to infection, and the incremental cost per life year gained is very low. Thank you. This is a surprising difference, and it might, of course, be related to a more intense platelet inhibition that might, in severe infections, there might be a thrombotic component, but it might also be related to other effects of ticagrelor in comparison to clopidogrel. We have seen some differences in the inflammatory response between the two treatments when we look into inflammatory markers. And of course, the hypothesis might be either that ticagrelor is protective or that clopidogrel is in some way increasing the risk with infection because of some effects on white cells or other inflammatory responses. But this is now investigated further, even in other trials, and there are trials trying to see whether in pneumonia patients ticagrelor might be beneficial, and in CABG patients specifically. So I think we will learn much more about ticagrelor in infection in the future. The addition of additional platelet inhibitors beyond aspirin and ticagrelor, of course, has been tested concerning clopidogrel. So aspirin, clopidogrel, and another antiplatelet inhibitor has been found to have some additional benefit concerning ischemic events, but it simultaneously increases bleeding. So the bleeding issue becomes a complex issue. And when you increase bleeding substantially, you increase also mortality. So therefore, I think that the likelihood that further intense platelet inhibition on long term will not be beneficial, because if you increase bleeding, which we did not really do substantially with ticagrelor, then we will see detrimental effects on mortality.